Hi, and welcome to CMH Family Medicine Top Tips and Tutorials. I'm Dr. Madeleine Muller, and today we're going to focus a little bit on choosing a treatment regimen for your patient with heart failure. And I'm particularly looking at the chronic heart failure patient who's got chronic symptoms and who you don't, for example, need to admit for management. So diagnosing heart failure, I'm not going to focus on the signs and symptoms because I think you know these quite well, but very important. This is your most important part of actually deciding whether your patient has heart failure is the clinical symptoms of that patient. And you need to have a high index of suspicion, especially of those patients who are starting to get a bit of exercise intolerance. Examine your patient properly and start seeing if you can find any clinical signs or symptoms of heart failure. In any patient where you're suspicious, your next port of call is your ECG. And a normal ECG can be quite reassuring, and certainly any severe heart failure, we will already be able to pick up some signs on that ECG. If you do have an abnormal ECG, in our setting that I mean here at CMH or in a regional hospital setting, ideally you want to have that patient booked for an echo to be able to determine the ejection fraction. It would be lovely to have a BNP. All of the international guidelines and private guidelines are all based on using your BNPs to help confirm or exclude your diagnoses, but we don't have access to those in the public sector. So in terms of your baseline workup, if you've got your patient, your big thing is to try and identify if there's any risk factors or other risk factors or complications that you're also going to need to be managing. I've mentioned that ECG, but there's also quite often a temptation to do that standing X-ray. And certainly an enlarged cardiac thoracic ratio is very satisfying. Oh, good, there's a nice big heart. But actually usually just confirms what you've already found on your physical examination. And that's just important if you're in a setting where it's not so easy to get hold of an X-ray. Very important that a normal CTR ratio does not necessarily exclude your heart failure. And there's just a quick reminder on the baseline bloods that we need in all patients that we are diagnosing with heart failure. Important to screen for diabetes, important to screen that, do your lipogram, obviously do your cusp, and then that in part of your workup, you have to have a TSH, you have to have a full blood count and check for anemia. If the patient's very congested, you want to know what's going on with the liver function tests. And quite often we forget about the ferritin and the iron levels, which is important in terms of the progression and prognosis of that heart failure as well. And then, as I've mentioned, BNP, which we unfortunately do not have. So what to do if you're in a district hospital setting and you do not have an echo? And we're going to talk a second about reduced and preserved ejection fraction. But unfortunately, our clinical examination is not always going to tell us which direction it is. If you have a patient with very mild symptoms, very little changes on the ECG, you might guess that it might be preserved, but it's actually very difficult to tell. And so if the ejection fraction is unknown, I would recommend you err on the side of caution or discuss with a local physician and treat that patient as if they have reduced ejection fraction. So why does it matter? So especially in recent guidelines in the last few years, we now know that the ejection fraction makes a huge difference in what kind of treatment you're going to choose for your patient. So just to remind us on how we classify ejection fraction. So in our public sector setting, because of the access to drugs and follow-up we have, we're going to make it very simple. You're either going to classify your patient as preserved ejection fraction, so that's ejection fraction of over 50%, or a reduced ejection fraction, so that's an ejection fraction of under 50%. In the international guidelines, they also have a moderate reduction, which is between 40 and 50%, but it makes no difference in how we manage patients. So interestingly enough, we always tend to think of preserved ejection fraction heart failure as a milder type of heart failure, but these patients actually can do worse as we do not have any treatment that can convincingly reduce morbidity or mortality. For patients with reduced ejection fraction, though, there are very specific drugs that has actually able to reduce morbidity and mortality and can actually reverse left ventricular function and can actually improve that ejection function. And so these patients will need to go on a specific triad of drugs that we're going to go through now. So for your preserved ejection fraction, we're going to focus on symptomatic treatment. And for reduced ejection fraction, they're all going to end up on a combination of enalapril, carvedilol, and spironolactone. And let's just see how we introduce that. So for both our reduced and preserved ejection fractions, we treat them all exactly the same at initiation. It's all about getting that fluid down, and that's mostly for symptomatic relief. It doesn't have a huge impact on mortality, for example. Start with your 40 milligrams twice a day. And very important is to not pussyfoot in terms of putting that furosemide up. So double the dose until the patient is actually losing weight and the symptoms are getting better. And interestingly, and I didn't know this, that you can take your treatment on an empty stomach. It actually improves that diuretic effect. So to take that treatment before they have their breakfast or before they have their lunch, and to wait a little bit before they eat. And especially if you're in a district hospital setting and you can actually weigh your patient, you want to make sure that they're losing between 0.75 and 1 kilograms per day. And then interestingly, you can go up very high. So you can go up to 240 milligrams twice a day, and you're going to use that weight loss per day to help you get to target. Just note, if patients have got very mild symptoms and very mild edema, that you can actually just get away with a decent dose of hydrochlorothiazide. So again, for both our reduced and preserved ejection fractions, enalapril is definitely useful, and our preserved ejection fractions, it can help for symptomatic relief and reduce the amount of diuretics you're going to need to use long term. Remember, in hypertension, we use enalapril once a day. In heart failure, you have to use the twice a day dosing. So you'll start off with a 2.5 milligrams twice a day. That's a very low dose. And you're going to titrate up, ideally every 2 weeks, but if not possible, every 2 to 4 weeks. And you can go up to a maximum of 20 milligrams BD. So remember, this is not like a blood pressure where you're trying to get to a blood pressure target. You're actually trying to get to the patient to be symptomatically as well as possible. Very important is to monitor that potassium 2 to 4 weeks after each adjustment, just to make sure that that patient is not getting a high potassium. So in our preserved ejection fraction, that's all you're going to do. You're going to diurese, you're going to add in your enalapril. But for our reduced ejection fractions, we also want to start spironolactone. And you can start that spironolactone early on, especially if the patient's very heavily fluid overloaded. And in your preserved ejection fraction, if you don't have an echo, you're waiting for an echo, lots of also very heavily fluid overloaded, I would also add the spironolactone at this point. So you would start off with that 12.5 milligram dosing, especially if you're also using enalapril at the same time. And then depending on your potassium is going to limit on how high you can go with the dosing of that spironolactone. So just watch out if they're also on that enalapril or losartan, that you might not get away with more than 25 milligrams of that spironolactone. So the idea is to get as much as possible in to be able to get mortality benefit. And so you're going to go up with that dosing of the spironolactone until as long as that systolic blood pressure remains over 90. And then finally, remember we talked about the 3 drugs for reduced ejection fraction, enalapril, spironolactone, and then your carvedilol you're going to actually add in once your patient is diuresed. So carvedilol is excellent for mortality benefit. Again, you want to get as much as possible on board as what the patient can manage. You're going to start on the very low dosing. That's mainly also from a side effect point of view, 3.125 milligrams BD. And again, you're going to double that dose every 2 to 4 weeks. So we can go up to a maximum of 25 milligrams BD. So that's quite a high dose. And to not be worried as long as that pulse rate and blood pressure is monitoring. And you can see as long as the blood pulse is over 50, and if the patient is not having any negative side effects on the carvedilol, you can continue to increase the dosing for your patient. And then just a last couple of notes on a couple of other drugs when you're monitoring your patient. So digoxin is not something that we would really use on a district hospital setting, and those are usually going to be as recommended by a physician, and that's usually patients who are not being controlled on maximum dosages of your 3 drugs. So if you have patients on digoxin historically and sort of been started years ago and everybody's just been continuing that script, you can confidently stop that digoxin. Quite often in low dosing, it doesn't do anything, and in high dosing, it's potentially toxic. Other options, if you have, for example, either issues with renal function or adverse events on some of your other medicines, a nice combination is that of hydralazine and isosorbide. Unfortunately, they are 3 times daily dosing, which is why we don't like using them as first-line treatment. And again, you can slowly increase the dosing of that until your patient is well managed.